India is going through an unprecedented crisis with shortage of beds, oxygen, and medications for patients with COVID-19. We at Stanford University wanted to share what we learned from our experiences managing patients with COVID-19 in the hope that it helps patients, families, and our peers in India. We want to address some of the common questions that have been asked of us by our patients and families here. With that, I want to introduce our panelists, all of whom took care of several patients with COVID-19 here at Stanford. Dr. Andre Kumar, who practices general medicine and manages patients in the hospital. Dr. Shanti Kapagoda, who is an infectious disease specialist at Stanford. And Dr. Angela Rogers, who is an ICU doctor and lung specialist at Stanford. Andre, I'm going to start with you first. So what has been the usual clinical course for patients admitted with COVID-19 here?
That's a great question. What we typically see for patients who are admitted to the hospital is for the first 48 hours, that's when I find it's most critical for them, and the likelihood that they'll decompensate and require mechanical ventilation or an ICU admission is the greatest. Usually after the first 48 hours, if we have them on therapies and a stable level of oxygen, it's been very rare for me to actually see patients further decompensate. The one caveat to that is we do know that COVID-19 predisposes patients to a much higher risk of thrombosis and pulmonary embolism. And so if that does occur later in the hospitalization, that's something that does warrant further investigation, for at least in my experience.
So when do you start worrying that the patient may need more care, like in the intensive care unit?
What we've been doing at Stanford is we generally keep patients on the medical floor as long as they are requiring 6 liters of oxygen or less, and if that oxygen requirement is stable. If a patient is starting to require more than 6 liters, or we're noticing a rapid uptitration along with significant respiratory distress and perhaps tiring out of the patient, then we consult our ICU colleagues to evaluate them and consider an ICU admission.
No, thanks, Andre. So on the flip side, when do you start thinking that this patient is starting to recover now?
What I tell a lot of my patients with COVID-19 is that the recovery can take a bit of time, and it's an important expectation that I set with them. We know that patients who are hospitalized with COVID, for instance, 87% may still experience symptoms a couple months after. So I tell them you're not necessarily going to feel normal even after you leave the hospital. That being said, I do expect you to continue to improve over the next several weeks. My criteria to consider discharge are if we have someone who is on oxygen, that amount of oxygen has been stable for the last, I would say, 48 hours. The amount of oxygen they're requiring is 3 liters or less, and they can maintain their oxygen saturation above 90%, whether they're at rest or with their ambulating. And then the other really important thing is that they just have the ability to monitor themselves at home. And if there is a risk that they could further decompensate, we obviously give them very strict return precautions.
Thanks, Andre. So you mentioned 90% of oxygen. So for patients who are stuck at home in India right now who don't have a bed, how much oxygen level is good enough for a human being? And Angela and Andre, feel free to chime in.
Yeah, that's a really great question. It depends a little bit on the individual patient and what their respiratory status was before they had COVID-19. Some patients were on oxygen prior to that. What we sort of use as a marker for the severity of COVID-19, which is a definition provided by our government, the National Institute of Health, is anyone who has an oxygen saturation of 94% or less. On-room air is considered a severe COVID-19 patient. For patients who are at home and on oxygen, what I generally would say to some of these patients are, if you notice that the oxygen level is going up beyond 6 liters, or you feel significantly short of breath, like you can't catch your breath, that is a time to consider evaluation by medical staff and personnel.
And I would agree, just as a lung doctor, that's what we target. There's not an advantage to having an oxygen of 97 over 90. Any of those are fine. You know, if you're a previously healthy person, that's good enough. To get oxygen for home around here, you have to prove that you fall below 88%. but certainly being in the low 80s does start to really stress your heart and brain. And so just as Dr. Kumar said, having some wiggle room there and targeting being in the 90s is a good thing to be doing. And watching your loved one, if you're the person who's feeling okay, how short of breath do they look? You can have people that are really working hard to breathe, and you can see they can't speak in complete sentences, they're short of breath, they look a lot worse than they did yesterday. Then don't let yourself be totally reassured that their oxygen's 92. How they look, are they worsening, is really important to watch for as well.
No, thank you for that. So it's just not the number, it is also how they look that is very important in this. So Andre, I'm going to go back to you. What are the initial blood work? What are the blood tests that we have done for patients who have been asymptomatic and just found out that they have COVID-19 versus those who have mild disease, moderate disease, or are very, very sick, severely ill?
When we think about COVID-19, I use the guidance that's been provided by our government, the National Institute of Health, in defining some of these diseases, for instance, mild, moderate, or severe. For asymptomatic patients, patients who test positive but have no symptoms, we generally do not do any additional tests. We just give them guidance of the course of COVID and caution them of things to seek medical care for. Mild disease, our government defines essentially as symptoms of an upper respiratory infection that you might see with COVID-19, fevers, coughs, sore throat, perhaps GI upset, but you don't see things such as shortness of breath. In those particular patients, we also do not advise to do a test for them, and we also give them just caution and return precautions. When we start to have patients with moderate disease, so those are patients who start to develop shortness of breath, or they feel like they have a difficult time moving around without feeling winded. Those are patients that we consider for evaluation, and those tests can include a chest x-ray to evaluate for perhaps respiratory involvement. And then for our most severe patients, those who have evidence of respiratory involvement on their exam or imaging, and who have an oxygen saturation of 94% or less on room air, or a respiratory rate above 30, those are the patients we typically order labs on. And typical labs we will do for them include a CBC with the differential, a chemistry 7, liver tests to specifically test for AST and ALT, which might be important with treatment. Some providers also do ancillary tests such as a C-reactive protein, a D-dimer, and procalcitonin, which are additional tests that they may do for risk stratification. But the main things we really want to monitor for these particular patients, at least in my practice, is the complete blood count and the liver tests, especially if they're on treatment.
Thanks, Andre. And Angela, let me ask you this, that what if a patient who's trying to manage it at home in India where access to getting these blood work is very difficult, then how important, how urgent it is that they get interleukin 6 level or a CRP level or ferritin or LDH, lactate dehydrogenase? Is it something so critical in COVID-19, or is it just really how the patient looks?
No, I would say we do test some of those. We send them, but it doesn't change our management at all. I think, IL-6 levels, CRP levels are higher in people who are sick, but they're also often a little bit high in people who look great and need no oxygen. And similarly, we've had intubated patients where the levels aren't high. And so I would say that wouldn't at all be a priority for me for helping care for my loved one. It would really be about oxygen.
Thank you. So when do you do a CT scan for a patient? I know that there's been lots of conversation about chest X-ray and CT scan of the chest, things that we think are readily available here for our patients, but extremely difficult to get there. How do you manage that?
I would say, again, just like the blood work, I think often imaging kind of tells you what you can see by seeing the patient as they're breathing. We do often get CT scans to look for blood clots. Dr. Kumar mentioned we do see it a lot more in COVID. That's a way that COVID is different than a lot of the normal bad viral infections, that there's so much blood clotting. So if the person is saying, gosh, every time I take a breath, I have this horrible pain, or other physical findings that suggest a blood clot, that's a good reason to get a CAT scan, I would say. I have heard that for some people in India, it's easier to get a CAT scan to show the classic findings than it is to wait for a nasal swab and be sure. So I've heard that that is something, that's kind of a different way of getting the results back quickly. But for my clinical practice, it does not change my mind. We have, again, some people who need the ventilator, whose chest x-ray doesn't look that bad and their CAT scan, and other people whose lungs look just horrible, but they are breathing pretty easy. They're doing a lot of self-proning. If that's going to be something we talk about, flipping over, their oxygen is over 90 and they look okay. I would love to not intubate that patient, and there's nothing on their CAT scan that would change my mind. So I would, unless you have this issue that you can't really you're uncertain of the diagnosis, do they have something that's not COVID? Or if you're worried about a blood clot, those two things would make me as a doctor really want that test.
Thank you both. So, Andre, if there are multiple people in a household with COVID-19, and in India, usually, there are bigger families and in a smaller space many times, do they still need to isolate from each other or wear masks at home? Or just because everyone in the home tested positive for COVID, they could all just kind of be in the same space and don't really have to wear a mask?
That's a great question. What I have been telling my patients, and we have experienced many individuals who live in a small quarter here in California as well. I tell them as best you can, try to isolate and still try to practice precautions. The reason being is we now know there are several variants going around. But more than that, it's trying to protect the most vulnerable people in the household, but also making sure that individuals who may not quite yet have developed COVID do not acquire it and pass it on to someone else. What I tell my patients, what I've been doing in my practice is I encourage them to wear a mask at all times as best they can, try to isolate from other individuals in the household, make sure it's a well ventilated area if possible. Wiping down very commonly used surfaces with soap, water, or a diluted bleach solution is something you can do. We find that the risk, however, for COVID-19 is mainly through the air and a respiratory, very minor with contact with common surfaces, but nonetheless, it's still a great practice to do. And then I encourage all my patients to wash their hands frequently if possible and avoid touching their face.
Thank you, Andre. Shanti, I wanted to ask you that we started with nasopharyngeal swab testing for COVID-19, but do you think that saliva tests or oropharyngeal swabs or nasal swabs are equally acceptable?
Yeah, I think nasopharyngeal and nasal swabs, meaning either the anterior nares or the mid-turbinate, and saliva have equally high sensitivity. The one that may have slightly lower is the oropharyngeal, so maybe that would be a bit less preferred.
So if a patient there has only access to oropharyngeal or they had a prior surgery in the nose, if they can get an oropharyngeal, should they take it, or they should just assume that they have COVID because they have symptoms?
If it's, if everyone in the household has COVID and you're also feeling the same, chances are very high that you do have COVID, and a test would not really change management necessarily. So I don't think straining resources to go out and get this test is necessarily your highest priority. Maybe just staying home and managing your symptoms might be good.
So Shanti, I know there have been lots of medications for COVID. It is a very confusing landscape. What medications do you think have the best evidence for treatment of COVID-19? And in particular, if you can comment about remdesivir in the context of variants in India.
Yeah, well, for us in our setting, we divide the medicines into things that help people at home, outpatients, and things that are useful in the hospital. The thing that's been most useful in the hospital is dexamethasone, which is a steroid medicine that calms down inflammation in the lungs. Another medicine that has shown to be helpful just in people who are really sick, like really needing the ICU, the type of patient Angela sees, is a medicine called tocilizumab, an IV infusion. The remdesivir that you mentioned is another IV medicine, and it doesn't seem to decrease the chance of dying if you get COVID. it does seem to maybe shorten the length of time you need to be in the hospital or the length of time you have symptoms. So if I were running a hospital, the main thing I would be prioritizing is dexamethasone and of course oxygen.
Thanks, Shanti. So right now, as you know, that a lot of these medications are being given at home because there is no place in the hospital. So would you think that a patient who is at home should take remdesivir or tocilizumab or dexamethasone? And if so, which are the patients who are at home can actually still benefit from these medications?
Yeah, I think if you are home but needing oxygen to breathe comfortably and to keep your oxygen level, as we said, above 90, then you are likely to benefit from dexamethasone. We usually give 6 milligrams for 10 days or until the person feels better. If dexamethasone is not available, there's some equivalent similar medicines like prednisone or hydrocortisone that do the same thing, and then those can be substituted. So I don't think if you're needing oxygen at home, it seems reasonable to me to take dexamethasone, even though that's not our normal practice here. The remdesivir, as I said, I don't think it has a major life-saving benefit. I do think it's not a harmful medicine. It's very safe. We have given it to thousands of people and they've done fine. But I wouldn't say it has a life-saving benefit. So if that is expensive or hard to get, I wouldn't put my efforts trying to track that down.
I think another important point is that the trials that showed such good results in very sick patients who need oxygen for dexamethasone had a trend toward harm in people who didn't need oxygen. And so for me, that's a very important line in the sand, is that the people in the house that are feeling okay and, checking their own oxygen, it looks good, those people might actually be harmed by doing it. And I would say that I think human nature is human nature. We're all do something people, and it certainly early in COVID, people were reaching for lots of different things. And I know that there's a strong drive to just do something rather than do nothing. And our experience in medicine is very much that often if there's not a strong indication for something, those things can be harmful. And so it's not a long list that Dr. Capagoda just said, but I would agree with her that many of the over-the-counter things that people do are reaching too early for Decadron when you're not that sick may actually put you at risk. Your immune system may be handling the virus just fine, and you're better off without knocking your immunity down unless you need oxygen. So I would really advise you and your friends to consider not doing those things as long as you're feeling okay, but watch your oxygen carefully.
Thank you both. This is a very important point. So I'm going to ask you a follow-up question. That sometimes steroids have been prescribed for breaking fever, and people are asked that fever is kind of a response that your body has. It's just telling you that it's dealing with the infection. So if you suppress the fever with things like paracetamol or what we call Tylenol here, it's actually harmful, and instead they should take steroids to break the fever. What do you think is happening there?
Well, I think a fever is very common in COVID. About 60% of patients will have a fever. And I think it's fine to take paracetamol. I don't think it's harmful. I don't think it's going to lengthen the time that you feel ill. And I also think it's fine to take other anti-inflammatory medicines in the category of brufen, or in America we call that ibuprofen. I would not take steroids just to break a fever. I don't think that's a good choice. I would be worried, like Angela said, about people using steroids. For us, that's things like dexamethasone or prednisone, using them when they don't need oxygen. So we would say they don't need the steroids, and it can cause some harm, especially if you have diabetes, and it can give you high blood sugar and other complications.
What about tocilizumab? You mentioned that medication, and I know that in India, there is a way to acquire every single medication at home. Is that a medication that you think could be given at home, should be given at home, or if it is given at home in desperation, then what are the most common things that people should watch out for?
Yeah, that is a tough one for me to answer because it would be an unusual situation where I think it would make sense to take tocilizumab at home to be honest. The people who benefited most from tocilizumab were ICU patients, so people who are about to need a ventilator or needing so much oxygen, it's more than you'd get through just nasal prongs. And so, or people who are needing medicine to support their blood pressure. So I feel like, if you're in that situation, really, we would want you to be in the hospital if that were possible. And in that setting, we would probably give the tocilizumab. At home, with a milder illness, it feels, there's some risk associated with it, can affect your immune system, make you more prone to other infections, can affect your liver. And so I would feel cautious doing that at home. At least for us, it also would be a very expensive medicine. And I'm not sure I would put my resources there.
So Shanti, what do you think is the role of ivermectin or other antivirals such as favipiravir or hydroxychloroquine and doxycycline in COVID, because they have been prescribed in several other countries, including India?
I think one easy answer is that hydroxychloroquine is shown to have no benefit and even to have harm to increase the chance of dying if you have COVID. So I would definitely avoid that. Ivermectin, which is an anti-parasite medicine, has not been shown to be beneficial in a clinical trial. It was studied in Colombia and showed no benefit. Doxycycline is an antibacterial medicine. I'm not aware of any trials studying that for COVID. A somewhat similar medicine, azithromycin, has been studied in a couple of big trials and showed no benefit. Favipiravir, I'm less familiar with, as we don't have that. I think there are ongoing trials now. I think there were a couple small studies showing a benefit last year in the pandemic, but subsequent study in Iran that I saw showed no benefit. So I think we can't say for now if there's a benefit or not for favipiravir, but there's no clear evidence that there is a benefit in the studies that we see.
Thank you for that. So I guess what I'm hearing is that there is no proven benefit, but we at this point, if my neighbor is taking it and I feel that I need to do something for myself, then can I take those medications still? Because my neighbor took it.
I do think there's harm. We can do harm. All these medicines have side effects, can affect your liver or kidneys or something. So I think if there's no clear benefit, it's probably not helpful. You're just as helped by just, resting and fluids and paracetamol and cough suppressive medicines and doing breathing exercises and simple things like that, as to take these medicines that don't seem to have a.
So I know that the feeling is that you want to do more, but actually less is more. The less you do, the more chances that you will protect yourself from the harmful side effects of many of these medications.
I agree.
And that really has been our practice here. When people don't need oxygen, we watch them carefully. Exactly what we're suggesting people might be wise to do at home is exactly what we do here. We do not treat with lots of vitamins or extra antibiotics that have no proven benefit. We just watch carefully.
So, and that goes for probably vitamin C and D and zinc. You don't necessarily need to take it. You probably can just get by with focusing on better nutrition as your body allows.
Yeah, I think those things are probably harmless, vitamin C, zinc, vitamin D. So I don't feel, very strongly that you must avoid these things. But unless you have a deficiency, taking them is unlikely to help you get better, I would say.
Thank you. So Angela, you took care of the sickest of our patients in the intensive care unit. What was the typical clinical course of patients who stayed on high-flow nasal cannulas, and how did you decide that this patient is okay on high-flow nasal cannula versus this patient who needs a ventilator?
Really it was a lot about the physical exam, exactly like Dr. Kumar on the wards. It was a very close monitoring together. Some patients could come to the intensive care unit. They needed a lot of oxygen, an amount of oxygen that you probably can't do at home. But with that high flow, people could often avoid a breathing tube. Early in the pandemic, we had heard that maybe it was best to intubate early, and our practice very quickly changed, realizing that a lot of patients could just get a lot of oxygen and continue breathing for themselves. We haven't talked a lot about proning, but that's something everyone could do. And I think Nidhi will have the link for her website that has some examples of how to do that. But really, we did see a lot of patients whose oxygen level was a lot better on their stomach. And it's weird, but it works. And people would be on their stomach for days most of the time. They'd flip over to eat or to use the bathroom, and their oxygen would temporarily be in the 80s, and then it'd settle out, and then they'd go back on their stomach. And that's certainly something. It's free and it seems to work. And so that would be something I definitely advocate. And we used it in the intensive care for people on high flow or people who had gotten off the breathing tube and were getting better. So that it just seems to distribute the blood better. So that was something we did. Just as Dr. Kumar mentioned, it takes a long time to get better. And we saw that in the ICU too, that often people who needed a breathing tube, it could be a really long time for some patients, but we did see patients that could weeks later get better. And I will say, as I hope soon stress level comes down in India, where people who need a hospital can have a hospital, that has been something that I've seen here, is that people are so frightened to go to the hospital because they're worried about what would happen. And I always say, if your oxygen's in the 80s, you need more oxygen, you need your bedside nurse. So as you're able, please think of hospitals as a place where you can go to get better. Even in the ICU, a lot of our patients did get better and could even walk out. Even if they were in the ICU on a ventilator for weeks, it doesn't mean they can't get better. They just need a lot of care.
No, thank you, Angela, and really like spectacular care of patients, and lots of the patients did so well. You mentioned proning, which is a very important technique, and that was something new that we all kind of learned with COVID. There have been questions that because there is no bed, and if the oxygen saturation is falling below 90, what are the things that patients could do at home if they don't have access to oxygen? So proning is one of the things that they could do. Is there anything else that you can think of, any magic thing that they can do at home while they're in the waiting line to get a bed in the hospital?
I do think Decadron is something in that context, without question, I would want to be getting. I think we see a lot of patients that are kind of okay at rest, and then when they start moving are really, really having low oxygen. So that is a place where having someone there with you to help you, monitor you, that to monitor that sick patient, to get them their food, that person is best served to just mostly be proning and try to have everything else taken care of, so there's not extra work of walking. But unfortunately, it's so hard, because what you really might need is a lot more oxygen than you can get at home. So we use oxygen levels of 50 liters, like tons and tons of oxygen, which can really only be done in the hospital. I don't know what can be gotten at home, but even sometimes our lung transplant patients, to try to get home, we'll have 2 nasal cannulas, so 2 tanks at 6 liters to try to maximize that. So that might be one other option. If you have a friend who has CPAP that fits your face, that, if your oxygen's really in the low 80s, again, the right thing is to get the breathing tube and to have a nurse there who really knows. But, anything you could do like that to bring the oxygen up would be something I would certainly try if that was my only choice.
That's excellent, actually. So if the oxygen levels are dropping, first of all, don't panic, because otherwise you just make the situation worse. It is easier said than done, but proning is a technique that can be used, dexamethasone or any other steroids that may be available. And you mentioned that using 2 nasal prongs with 2 cylinders, what is the benefit of that? And it is very uncommon to hear about that. So tell us a little bit more.
It's just sometimes, for us, typically the max is like 6 liters that you can do on a regular canister. And for some people, when they walk, that's not enough. They might be okay. And so for them, it's a matter of, can I be at home? It's rare that we do this. It's just a trick that we sometimes do with patients that have really, really terrible lungs. Again, for a COVID patient, just as everyone's been saying, if at all possible, one of the most important things the hospital has is a nurse and people who can be there kind of with eyes on you in case you worsen and get you to ICU if you need it. But if that's not a choice, then just, if you're breathing fast, then you're getting some amount of oxygen through your nose and some amount through the air. And if this can be more, that's why high flow helps. A lot of our patients came to the ICU, they didn't get anything other than Decadron. They just got a lot of oxygen and a careful eye, and did a lot of self-proning, and were able to just skate through for some days and even weeks, and then they'd come back out and be perfectly okay. But it's just it's more oxygen, because you can't live in the low 80s. It's just, you can't, it's not enough for your brain, it's not enough for your heart.
Thanks, Angela. So, Angela, what do you think is the role of inhaled budestanide in the treatment of COVID-19? Who can take it? And Shanti, feel free to jump in as well. Is there a certain population who should take it? Is there harm in taking it? Is there benefit in taking it?
So we actually are doing trials in regular pneumonia of inhaled steroids. It has anti-inflammatory processes. We know Decadron is helpful if you're on oxygen. In the United States, they are rolling out trials of inhaled budesonide for patients with outpatients with COVID. I would put that sort of like Dr. Capagoda said, vitamin C and vitamin D seem unlikely to hurt you, to me, especially given that we know that for sicker patients, systemic steroids worked. So I would say that that's an okay thing to be taking. It's not something I would, leave my loved one and spend hours driving to go find. But I think, it's very commonly used in asthma and probably unharmful, and it might help. We just don't know that yet. But I would feel much safer taking that than the other drugs you mentioned, azithromycin, doxy, anything that is much more likely, I think, to have side effects than that.
So were there any special instructions that you were giving to patients with asthma or diabetes or immunocompromising conditions that you would see in the outpatient setting, for example?
Instructions for people with COVID?
Correct.
I think really it's very much the same. I do think for immunocompromised patients, especially if it's early on and you just got COVID, if it's at all possible to get a monoclonal antibody, therapy, that would, I don't know how possible that is in India, but that would be a group that I would think would be especially likely to benefit from that. Other than that, I would say it's very much the same, watching your oxygen, having people there that can help you, and bring you in if that's at all possible, if you do get worse. And if the oxygen falls, Decadron.
So it's really the immunocompromising conditions that we need to watch out for more carefully.
That makes me worry that your time to clear that virus might be especially long, and that you might be that person that convalescent plasma, if a monoclonal antibody isn't available for, I would reach for. And we still do that. If we can't get an inpatient monoclonal antibody and it's a person who's very immunocompromised and we're pretty sure they're early in their course, we do that.
So one of the last few questions for you is that, did you see a lot of bacterial lung infections in patients with COVID-19? And how did you suspect that this patient has a bacterial lung infection on top of COVID-19? What were the signs and symptoms? What was telling you that?
We did see it in part, as I said, because our patients were on the ventilator for a really long time. So I might defer to Dr. Kumar, whose experience probably is more similar to what we're talking about, patients that are trying to limp through without the hospital. But I would say in general, it was a patient who had things were kind of okay at whatever level they were at. And then suddenly new fevers, new thick phlegm, suddenly getting a lot worse. That would be sort of some of the worrisome signs that would make me want to get a chest x-ray and look for a different pattern of pneumonia. But Dr. Kumar, you might have other thoughts from the wards.
I completely agree with you, Dr. Rogers. The ICU is a different setting where mechanical ventilation, there's a higher risk of an infection there. I generally did not see a lot of secondary bacterial infections in our COVID-19 population. Some of the signs already mentioned by Dr. Rogers may be a potential clue. It's also just helpful to know a little bit of the time course of COVID and when patients are at highest risk for developing respiratory failure. We see in most trials that range is generally 7 to 15 days, a median of 12 in several studies. And so knowing that patients are likely to develop findings on their chest x-ray then to me is more suggestive of COVID, barring any other strong evidence otherwise. But once I get beyond that, let's say I've had a patient who's been in the hospital perhaps several weeks, or they've had COVID for several weeks, and now they're starting to develop new symptoms of worsening cough, worsening shortness of breath, more sputum, that might be a time I would consider a secondary infection.
Thank you, Andre. And Andre, you had mentioned that COVID doesn't go away as easily. It's the symptoms that keep on lingering on for some time. What have been the most common residual symptoms after the patient has recovered from acute COVID? And when should the patient start seeing a ray of hope that they are actually recovering?
It's a great question. It's still an area that we as providers are still grappling with, and there is this syndrome of post-COVID that we're seeing quite frequently. Some of the most common symptoms we are seeing in several studies include fatigue, shortness of breath still persists, cough. We're also noticing a substantial portion of patients, particularly elderly, develop some sort of cognitive dysfunction, meaning a little bit of confusion, a little bit of memory loss. And that's something that is important for you to keep an eye on for your loved one. These symptoms may persist, especially if you are requiring oxygen. They may persist for several weeks, if not months. And that's something that I want to caution, or I caution my patients about, and something that I tell them to potentially expect. I do tell them that you, in general, should be improving a bit by bit each day, especially after you're a couple weeks out from your COVID. But the complete resolution of your symptoms may not be something you see for quite some time.
Thank you for that. So with that, I would want to end and thank our panelists for making time and sharing their experiences for our patients at Stanford. We stand in solidarity with our peers in India, and we really hope that this discussion was helpful to patients everywhere. We are also trying to organize a live webinar where doctors in India can ask questions from a panel of doctors at Stanford who took care of patients with COVID-19 here. Thank you.